All right. Hey everyone, for this video we are going to go over how to spinally immobilize someone to a long spine board. So starting out, I'm going to go over the equipment that you need and then we will go over the procedure itself. So equipment that you'll need, obviously you're going to need a backboard. Your normal backboard is about 6 feet long. On the top of it here, this is called the headbed. So it's what we secure the parts that will hold the patient's head in place. So my lovely assistant here, we have our head block securing straps. There are 2 of them. So we'll set these aside for when we need them. These are our head blocks. So these go on the headbed to actually hold the head in place. If you look and see, one edge of this is flat and the other edge is slightly angled. So you'll need to note which side is flat when we get to that point because the flat edge goes against the patient's head. So we'll set those up by the patient's head for when we get there. Then the last thing you need is 3 9-foot straps. So this is our 9-foot strap. Unbuckled, it is 9 feet long. So we have 3 of those that we will use when we get to that point. Pull these out of the bag and pre-stage these for when we get to that point. All right, so starting out, we've already got our C-collar on our patient. So Paige is going to take C-spine. All right, so we've made contact, we've got C-spine, we have our C-collar in place, and our assessment has determined this patient has injuries consistent with needing spinal immobilization. So they have a suspected spinal injury, so we need a way to get them off the ground, keep their spine perfectly in line while we take them to the hospital. So our first step before we do any kind of splinting is we need to check what we call CMS, which is circulation, motor, and sensation. We're going to check that in all 4 extremities. Technically, we should do this before we even put the collar in place because the collar is a type of splint. So what I'm going to do is I'm going to check the pulses on his radius. So he has good, strong, equal pulses. I'll ask him to wiggle his fingers for me, making sure that they all move normally. I like to have them squeeze my fingers, comparing both sides, making sure that they're equal in strength. And then I would just ask him, without looking, what finger do I have? Without looking, what finger do I have? So that gives me circulation, motor, and sensation in both of his hands. Then I would move down to his feet. And I would check his pedal pulse on both sides. Ask him to wiggle his toes. You can have him push down with his feet like he's pushing on a gas pedal. Pull his feet up towards his head, once again checking that equal strength on both sides. And then, all right, sir, which toe am I touching? Which toe am I touching? If you want to make it easier on your patient, you check the big toe or the little toe. The middle toes can be hard to distinguish between. Plus, how do you identify this toe? That's the little piggy that stayed home, I think. I don't remember, but they're hard to identify, so big toe, little toe. So now that I've done CMS in all 4 extremities, we can work on rolling our patient so that we can get them on the board. Rolling your patient works easiest if you have 3 or 4 people, but you can do it with just 2 people. So, anytime we move a patient, the person in charge of the movement is the person at the head. So Paige will be in charge of all movements that we do with this patient. So we are going to log roll him towards me. So I'm going to take this arm on the side that we're rolling onto and put it above his head. That way when we roll him, if his arm's at his side, when you roll onto it, you're going to manipulate the spine because it's not flat. So you put their arm above their head. That way it's a nice flat surface for them to lay upon. I'm going to take my head the closest to the hand, my hand that's closest to the head, sorry, and I'm going to put it up on his shoulder. I'm going to take my other hand and put it on his hip. Now if we had a third person, they would cross their top hand over or under mine onto the hip, and their other hand would go behind the knee so that we can safely log roll him as a unit. So we're going to pretend that we've got enough people to do this. All right, Paige, I am ready on your count.
All right, I'm going to roll on 3. 1, 2, 3.
So notice that Paige identified the movement that we were doing and what number we were doing it on, and then we have successfully rolled him. So now while holding on to him, I'm going to palpate his spinal cord all the way down, checking for any pain or crepitus, deformity, step-offs, other injuries. I'm going to look at his back, looking for other injuries here. Once I know that he doesn't have any injuries other than weird cords coming out of him, I'm going to grab our backboard and position it in place. So now that that's positioned, all right, Paige, ready to lower back down.
All right, back down on 3. 1, 2, 3.
Okay. So now looking at our patient, he is not straight on this board. And obviously, since we want to keep his spine straight, I can't just like push him a little bit to get him straight. So what we're going to do is called scissoring the patient so that we can get him straight on the stretcher. So once again, if we had enough people, I would grab the shoulders, our third person would grab the hips, and then on Paige's count we would move. All right. So Paige is going to identify our movement and count.
Down on 3. 1, 2, 3.
Notice how as we went down, we went over just slightly as a unit, so he's now centered on the board.
Up on 3. 1, 2, 3. Good.
Perfect. So now his head is squarely on the headbed. His body is right in the middle of the board. Now we can secure him in place. So to secure him in place, we are going to grab our first 9-foot strap and we're going to unbuckle it. We are going to take the female end, and usually you don't lean over your patient, but this way you will be able to see easiest. I'm going to take the female end and I'm going to find the hole in the backboard closest to the shoulder. And I'm going to feed the female end up and through that hole, placing the female end in the center of their chest. Now, trying not to get any twisties in my 9-foot strap, I'm going to go down and I'm going to find the hole that's near his hip. And I'm going to feed the male end up and through that hole. Once I'm through that hole, I'm going to make sure that this is going across his hip. We don't want it to be too high and go across his stomach, because if something happens and the belt tightens and it's over his stomach, we can damage